Up to Lesson 4, we have been examining what evidence is and why it is important. In Lessons 5 through 12, we shall learn how to practice evidence-based mental health. In the last lesson, we have seen that we have to pay attention not only to the absolute strength of evidence, because evidence comes in shades of gray, but also to the relative strength of evidence, because some of the so-called strong evidence may not be as strong as we had once believed. More importantly, however, evidence is not synonymous with evidence-based medicine. What then is evidence-based medicine? 20 years ago, Gordon Guyatt at McMaster University in Canada wrote, "EBM maintains that intuition, unsystematic observations, pathophysiological mechanisms, or expert opinions can no longer be an adequate basis for clinical judgments. Clinical decisions must be based on evidence from properly conducted clinical research." Dave Sackett also wrote, "Evidence-based medicine is the conscientious, explicit, and judicious use of current best evidence in making decisions about the care of individual patients." To me, EBM refers to all the know-how about how to properly answer and solve clinical questions arising in the context of clinical management of each individual patient. In other words, EBM starts with a patient and ends with a patient. We therefore cannot practice EBM on evidence alone. In order to practice evidence-based medicine, we first have to assess the clinical status of the patient. Then we have to look for evidence that matches this clinical status. And the two together will work towards realizing this patient's values and preferences. And all these can only happen in the context of your clinical expertise. Questions that we encounter in our day-to-day clinical practices can be categorized into three groups. First, we have general questions such as, what is the executive function in the diagnostic criteria for dementia? Or, what are atypical features of depression? Or, what is common and different in the pharmacological properties of various new generation antipsychotics? Second, we also have focused questions, that is, questions concerning care of this patient. For example, which antidepressant at what dosage shall I prescribe for the patient with a new onset major depression that I saw today? The patient admitted into the acute care ward 3 days ago may have malignant syndrome. How can I make definitive diagnosis? And in clinical practices, we also encounter questions which I call life enigmas. For example, a 95-year-old man, bedridden and unresponsive for 2 years with Alzheimer's disease, has contracted pneumonia. How aggressively can we treat him? A 40-year-old woman has become depressed after knowing that she has terminal cancer and only a few months to live. How should she spend the remaining days? In order to answer general questions, you have to look up the textbook or the dictionary. Or these days, you can simply Google the internet. EBM comes into play when you answer focused questions. Then there is no single correct answer to life enigmas. Since EBM, formerly known as clinical epidemiology, has been practiced in the 1980s, we have gradually learned that focused questions can be categorized into 4 areas. That is, questions concerning diagnosis, treatment, prognosis, and side effects. These clinical questions can be answered in 4 steps. Step 1, formulate your clinical question in an answerable manner. Step 2, look for evidence efficiently. Step 3, critically appraise the evidence candidate that you have found in Step 2. And in Step 4, apply the results to your patient. Note that we have 4 cells for Step 3, but only 1 cell for Steps 1, 2, and 4. Steps 1, 2, and 4 are by and large common to all the 4 types of questions. However, what constitutes the best evidence may depend on the clinical question you have. Earlier, we have learned that the best evidence for treatment may come from RCTs or their systematic reviews. For the other questions, the best evidence may come from other types of studies. In order to learn more about these steps, you may wish to read one of these textbooks. The first one, written by me, is entitled Evidence-Based Psychiatry. It is in Japanese. Second and the third are the most popular representative textbooks of evidence-based medicine worldwide.